For example, the date of birth has been entered incorrectly, or there is an omission or incorrect coding where the resident was admitted. Taking a second look at this section could diminish the number of data entry errors made by the facility. For Section A, although the Assessment Reference Date, or ARD, is identified on the MDS, at times facility staff will either complete the assessment or document findings that occurred before or after the established ARD. In either situation, valuable resident information is being omitted or unable to be captured due to the assessment being completed outside the observation period. Providers need to be sure that all members of the interdisciplinary team are aware of the established ARD and are aware of the specific observation periods for each specific section of the MDS. Not all sections have a 7-day look-back period. Some cover 14, other 30 days, depending upon the MDS section. However, the ARD is the date when all MDS observation periods end.
So, Michelle, it sounds as though this is a pivotal date and it's got to be taken seriously.
Yes, it is. Another item under Section A where we have found discrepancies is with advance directives. Upon admission to the facility, a resident may not have had any advance directives. However, over the course of their stay, an advance directive gets completed and it's located in the chart, but the MDS does not get updated with that information. With Section B, our discrepancies for this section usually are due to the facility coding short-term memory at the resident's highest level versus the most representative level of function. Therefore, a resident with a short-term memory problem 6 out of the 7 days should be coded as a 1. For Section C, the various findings in this section are due to the facilities not recognizing that C1 through 6 have a 7-day look-back period, while C7 has a 90-day look-back period. Here's an example where information can be omitted or not captured accurately due to not realizing the correct look-back period. Section D, major discrepancies in this section, is failure to capture visual appliances under D3. This is an MDS item which is found most frequently on 2-stage review, since we actually observe and interview the resident. During the reconciliation, this gives us an opportunity to point out the omission to the facility clinician. For Section E, as demonstrated on our clip of the reconciliation, discrepancies have been identified in this section due to facility clinician not realizing that the mood items can be coded even if it only occurred once during the 30-day observation period. In this particular section, we will also find contradictions between social service notes and the nurse's notes. For example, social work will code resident as not resisting care, E4E. However, in the nursing progress notes or on the medication administration records, documentation will note that resident was combative with care or resists assistance with ADLs or refused medications or treatments. All nursing documentation would be during the observation period, therefore should be coded. This is where we will discuss with the facility staff that the coding for this item focuses on the resident's actions, not intent.
Okay, so are there other sections of the MDS where we may find contradictory information between different disciplines?
Yes. Section F is another one of those sections. Again, this is a section which is very often completed by social work, but when reviewing the activity notes, for example, we may find contradictory information for the resident's sense of involvement, relationships, and past roles.
All right, then how can a facility avoid these contradictory situations?
Communication between interdisciplinary care team is essential. Whether it's a short daily team meeting or more comprehensive weekly team meetings, it is absolutely necessary for all members to discuss and share information concerning a resident. In Section G, which is another section which requires communication not only for the interdisciplinary team members, but also for team members throughout all 3 shifts. It is probably the most challenging section of the MDS to complete and is the one section we spend a great deal of time on during reconciliation. Most of our discrepancies identified in Section G are due to facilities coding ADL self-performance based on what the facility clinicians feel the resident is capable of doing versus what the resident actually did do. The full 7-day look-back period is not utilized, nor are facilities capturing what the resident performed throughout the 3 shifts per day. A resident's ADL self-performance may vary from day to day and from shift to shift. Therefore, different levels of staffing assistance may be necessary for that resident depending upon the time of day. Many times the facility is providing more staffing assistance than they don't take credit for it.
All right. This MDS tool is fascinating. It seems to take in all the aspects of an individual resident.
It truly does. That is why it's so important for the data to be accurate in order to best meet the residents' needs. In Section H, the discrepancies are usually due to misunderstanding the definition of a scheduled toileting program. The revised REI manual has very detailed clarification for when to code this item and what is required to do so. I encourage all facility clinicians to review this section if they have not done so already. We are now up to Section I. In this section, we find facilities not coding for disease diagnoses that have a relationship to the current ADL status, for cognitive, mood, and behavior status, medical treatments, nursing monitoring, or risk of death. Instead, facilities list inactive diagnoses or omit diagnoses that have a major effect on resident care. For Section G, upon review of the medical record, documentation reflects resident has complaints of pain or of a fall, and the MDS does not have these areas captured. This is usually due to the clinician not thoroughly reviewing the medical record prior to the completion of the MDS, and these items are then missed or not captured. Discrepancies associated with Section K are many times due to the facility not being aware that chewing and swallowing problems are coded even when interventions have been successfully introduced. They will code this item as none of the above, when in fact they should continue coding as a problem.
Well, some of these misunderstandings or misinterpretations sound as though they can easily be corrected. Is that right?
Yes. It's just a matter of reviewing and referring to the REI manual for clarification. Some sections, such as L, are very simple items to correct because the issues here are usually lack of coding, that the resident has dentures and or removable bridge. Once these areas are shown to the facility, the usual response is, I was in a hurry and I didn't take the time to look. Moving on to the next section, Section M, the most significant finding in this section was the miscoding of pressure ulcers and staging of wounds. Facility clinicians were uncertain of the specific definitions of how to stage ulcers and how to identify the type of ulcer. When on site, Section M provided several educational opportunities for the reviewers to consult with the facility clinician and review the REI guidelines and the most recent clarifications on skin conditions. When reviewing Section N, the coding on the MDS would many times conflict with the information found in the activity notes. This occurred mainly when a non-activity staff member completed the section and the notes were not reviewed prior to completing the MDS.
Well, I could see where that could be a problem.
For Section O, the majority of discrepancies identified here involve miscounting the number of medications and the coding of injections. Facility clinicians required clarification of when a purified protein derivative, or PPD, could be counted as an injection. Discrepancies noted in Section P included miscalculation of therapy minutes. Some examples of those inaccuracies include rounding minutes off to the nearest hundredths, choosing a RUG score for a resident and then computing the total minutes of therapy required to attain that RUG score instead of determining the resident's need for therapy. Coding nursing rehabilitation, restorative care without meeting the specific REI guideline criteria. Miscoding restraints and devices. Miscounting physician visits and orders. Facility clinician required clarifications on how and when to count a physician visit, and frequently the facility misunderstood when to count change in orders. The tendency was to count each change in an order instead of counting how many days the physician changed the resident's orders. Section Q is a small section, and the inconsistent documentation noted here was regarding discharge potential. Conflicting documentation would be noted in the various parts of the medical record whether or not the resident expressed or indicated a preference to return to the community. The last section I would like to discuss is Section T. Areas of concerns here were for miscalculation of projected days and or minutes. Facilities would project for days and or minutes that could not possibly happen through the 15th day. Now, I do not want to leave everyone with the impression that these discrepancies occur every time we perform a day review. This is just a broad general overview of our findings and a few reasons as to why they occurred.
All right, thanks a lot, Michelle. The MDS seems to be a real valuable assessment tool for a nursing home resident. Well, that concludes the presentation portion of the broadcast. Now it's time to give you, the viewing audience, one final opportunity to ask our experts questions on all that you've heard today. To call in, you should dial 1-800-953-2233. If you'd like to fax in your question, please call 1-410-786-0123. And while we're waiting for our first caller, Heidi, let me ask you a question. Terry Moore told us a lot about the Paired Assessment Accuracy, or PAR reports. When will providers be able to access the reports, and when will they be required to use them?
Okay. Well, as Terry mentioned, we've completed the pilot test for the PAR report, and actually CMS is in the process of reviewing that and basically stepping back and considering what's the best way to nationally implement this effort. We are absolutely committed to getting the information out to the providers to help them improve the quality of their data, but we want to do that in a manner that helps them to accept the information and know how to use it. So once we review the pilot test report and consider national implementation, we'll go forward with that. However, we will not do that until we've coordinated this effort within CMS and also with the provider community, so we can do so in a manner that makes the distribution of the information in the reports helpful to everyone. So again, we're back to our coordination and providing information in a useful manner. With respect to the requirement to use it, I think as Terry mentioned, and I think as we believe most of the information about the DAVE project can be used by providers, it really can be used for them to help improve their own quality, data quality efforts, and their own internal processes to improve data accuracy. We do not have official requirements that they use this information. However, we view this information as just one additional piece of information that they can incorporate into their processes. So we know there's lots of tools and information out there to help providers, and we hope that this is just another additional piece of information that they can use.
Great. Thanks, Heidi. We're going to take a call right now. Cindy's on the line calling from North Carolina. Cindy, thank you for calling. Please go ahead with your question.
Thank you. I've been involved with the RAI since its inception in 1990. Has the DAVE contract taken into account the reality of turnover in nursing homes with the staff who complete the MDS?
Who'd like to take that?
Yeah.
Michelle?
Certainly,
Okay.
I'll take that call. Yes, in fact, when we do go on site, we do interview and we do ask the provider the length of stay for their MDS coordinator and their administrative staff. And we do look into that and see how long they've been in that particular position. And as you can imagine, if it's been a short period of time, they usually do require more training, more educational opportunities. When we go on site at that particular time, some of them get concerned because they may have just recently been brought to that role, but with the educational opportunity afforded by the DAVE team, it's been very helpful to them. And we certainly do bring that information back, and we are trying to log and keep that information handy so we know where the educational opportunities need to be.
All right, Cindy, thank you very much for your question. Heidi, let me come back to you one more time. We've seen how the DAVE QC tool is used by the DAVE reviewers. Is it going to be available to providers?
Well, I think we would like to make this tool available to others, as I said, just as another piece of information and another tool that providers could use. We are taking that into consideration and reviewing that possibility. Again, looking at it in terms of what are the various educational efforts that we can take. So we would like to be able to make it available to the provider community in the future. I would probably ask that you stay tuned to the website to see when we might make that available, but we'll have to look at the resources involved and how to get the information out. But it's certainly a goal that we're considering.
All right, thank you very much. Let's take another telephone call. We have Lori on the line calling from California. Please go ahead, Lori. Thanks for calling.
Yes, I'd like to know what is the date for the nationwide launch of the DAVE project, and will you be using the same format that you've just kind of outlined in your pilot that was used in your pilot states?
Jill?
Okay, I'll take that one. I think that we are, during the beta phase period, we did a lot of the analysis of our techniques, our protocols, and we're taking all of that into consideration as we refine our processes for going forward. I think that CSC has come to us with some recommendations on different methods and different ways of going forward and different time frames. I can tell you that it will be sometime this fall, and you will be hearing more information about that. We will post that type of information also on the website and also try to get that message out to you in other ways.
Okay, this website is a good idea. Bob, let me come back to you. How exactly do you let the state agencies and the fiscal intermediaries know about upcoming DAVE reviews?
That's a good question, Doris, and a lot of work goes into that. First of all, before we go on site, before we send a medical record request to anyone, we develop lists of providers for proposed review, potential review. It could be random, it could be targeted, and we include a degree of oversampling so that when we get responses from the states and fiscal intermediaries, we can process them and still have the requisite number. The next thing we do is provide those provider numbers to the appropriate entities, and only to the appropriate entities, and ask them if they have any activities going on with which ours would interfere. As I indicated earlier, we don't want to get in the way, we don't want to duplicate anyone else's activity, and we want to ensure that theirs gets done effectively. They interact with us, they give us information. We do not ever ask them to tell us the reason that they would prefer that we not conduct a review or that we defer a review. As everyone knows, the survey process is confidential. All we ask is that they tell us, please do not conduct one at this time, or talk to us later. At that point, we process those replies and generally then conduct our off-site review requests. And once again, before we go on-site, we send a notice to the entities, the FIs, the state agencies, and the regional offices, indicating that in the next couple of weeks we would propose to conduct an on-site review, and asking them to get back to us if that would be an inconvenient time for that. This process has worked very well in the beta and transition states so far. We need to get our job done, but we do not want to get in the way of anyone else who is doing their job. We do not want to cause a burden. We do not want to be redundant. And we intend to continue this kind of process as we go national.
Okay, thank you so much. Michelle, let me address this question to you. When you're on site doing reconciliation, is there any opportunity for this facility to share with you information about their response?
So glad you asked that question, Doris, because it's very important that everyone realize during our reconciliation phase with the facility, we want that dialogue between the DAVE reviewer and the clinician. We're on a fact-finding mission. We want to know why the facility coded a particular area one way or the other. Because as I stated earlier, the reviewer does not look at any of the facility's MDS or information prior to making out their assessment. They have to go and do all of their assessment, they have to go and talk to the staff, they have to then go and do the medical record before they even see the facility's MDS. If the reviewer doesn't have information that's available to them at the time to make their determination, and it is brought to their attention during the reconciliation by the provider, then certainly we take that and we say, that's certainly legitimate information for us to use. So that reconciliation phase is truly a dialogue. We want to know why people coded things in a particular way, and if the facility shows credible evidence and shows us where that information came from, absolutely, it goes right into that direction.
All right, thank you. We have another telephone call. We have Kathy on the line calling from Louisiana. Thanks for calling, Kathy. Please go ahead with your question.
Yes, I was wondering if you would repeat the website that was mentioned earlier in the broadcast, the brand new DAVE website that just got posted today.
Jill? Heidi? Jill.
I can do
it.
it.
Okay.
www. There it is, it's up there, .cms.hhs.gov /providers/PSC/Dave. So my compliments to the graphics team for getting that up so fast.
Okay.
Okay, thank you.
Thank
Sure.
you, Kathy. Let's go to New Jersey. We have Jeannie on the line. Thanks for calling, Jeannie.
Hi. Can someone on the panel tell us about how long it takes a facility to put the requested material together for an off-site review?
Yeah, I can answer.
Yeah, okay, Catherine.
The providers that we've worked with during the beta phase and the transition phase really notified us that it took about an hour to 2 hours to complete the entire process, depending upon how many records we did indeed request. We have really streamlined the process and revised our tools over a couple of times to make sure that we reduce the provider burden to much of extent as possible.
Okay. Jeannie, thanks for your question. Michelle, I have another fax here from you, from Janet Gerber. And Janet says, during the review process, especially on site, are any statistics gleaned regarding the amount of education provided to the facilities team regarding completion of the MDS? And she says, as a long-term care consultant, I consistently find a direct relationship between educational preparation and MDS accuracy.
Yes, actually we do. We do ask that information. We ask in our entrance conference, there are certain information we try to get at that time. And one of the questions we will ask is, how does the team get their information on how to complete the MDS? Where do they get their education from for that? How often do they update their knowledge base on the MDS? If they want to get information as to any changes that's going on with the MDS, how do they do that? And we get a feel at that point where the facility is going to. If we look like they don't necessarily realize that the CMS website is available to them for clarifications, we certainly bring that up to them. And but we do ask how they get that information and where it comes from.
All right. Bob.
And Doris and Michelle, I'd just like to add that also in our discussions, in our teleconferences with the state agencies, we share information about their educational programs and our findings. And it's been very helpful so far in terms of indicating where additional education might be helpful.
Okay, great. Well, it looks as though we have no more faxes and no more telephone calls, so I guess we're going to conclude our broadcast on this note. I hope that it has been helpful and informative. This broadcast can also be viewed in its entirety on the internet at www.cmsinternetstreaming.com, and you can see it for up to 1 year from today. If you prefer a videotaped copy of the program, you can purchase it from the National Technical Information Services at 5285 Port Royal Road, room 1008, Sills Building, Springfield, Virginia 22161, or you can call on the number 703-605-6186. Again, I'd like to thank all of our panel members and our viewing audience for participating in this important and informative broadcast. I'm Doris McMillan. Have a great day.